So the FORUM study stands for omitting radiation under maturity age. Children with acute lymphoblastic leukemia have an excellent chance to be cured with chemotherapy alone. However, those who relapse or have resistant leukemia need additional immunological methods to have a chance to be cured. One of the most successful and important tools is allogeneic stem cell transplantation. That means that stem cells from a sibling or an unrelated donor are transplanted after a preparation which is called conditioning regimen, and then the new cells, the transplanted cells, control leukemia. This approach has some side effects, acute, but especially long-term side effects, and one of the most commonly applied conditioning regimen consists of total body irradiation and chemotherapy. After 40 years of this approach, an international group of pediatric transplanters had the vision that we could omit total body irradiation and substitute it with chemoconditioning combinations. We came together in 2012 and decided to start a huge international collaboration because only 10% of patients are eligible for an allogeneic stem cell transplantation. And so we founded a group which was asking the question whether we could compare total body irradiation and etoposide with two different conditioning regimens. Nearly all European centers for pediatric stem cell transplantation contributed, and also South America, Canada, New Zealand, Australia, Malaysia, Israel and Saudi Arabia contributed in this randomized question. To our surprise, after an interim analysis in 2018, it turned out that after 400 randomized patients, TBI and etoposide was highly better and significantly improving overall and event-free survival compared to chemoconditioning. The results were initiating additional analysis, and after a final statistical evaluation, we had to stop randomization in December 2019, and we continue now with this trial where we recommend TBI etoposide for all children above 4 years with a sibling or an unrelated donor, and only patients without such a donor or younger patients should receive chemoconditioning consisting of a combination of fludarabine, thiotepar, and either busulfan or triosulfan. Also, some countries where total body irradiation in children is not available or not allowed could use this chemoconditioning regimen because it is still a valid option for patients who need an allogeneic stem cell transplantation. In the meantime, we have recruited nearly 1,300 patients all over the world, and of course it is important to follow these patients and investigate not only acute effects but also problems of the later phase of after allogeneic stem cell transplantation. So, for instance, a big concern is the incidence of secondary malignancies, but also a late complication which is called chronic graft-versus-host disease, and where we also have to investigate whether fertility issues can be improved and perhaps also solved are important questions we want to ask for the future. To our surprise, we did not identify any subgroup of patients, for instance, the younger patients or patients with a matched sibling donor who benefit from chemoconditioning compared to total body irradiation. So we really have now sound, updated new results to recommend the modern form of total body irradiation, which is well tolerated in most of the patients.
So we did another subgroup analysis, and just chemo-conditioned patients were included, and so we took a deeper look at the patients who either received busulfan or treosulfan-based chemo-conditioning, and what we found is that both of these treatment arms were faring equally, and especially for T-ALL patients, we found a very good results after treosulfan-based conditioning, which was some kind of new finding that we're going to present on the EBMT annual meeting in the upcoming weeks.
So for the future, one of the most important new developments is the use of less toxic chemotherapy, for instance by using bispecific antibodies, which are highly effective in reducing leukemia burden before allogeneic stem cell transplantation, because we know patients who are in good remission have a higher chance to be cured by allogeneic stem cell transplantation. And as an alternative to transplant, of course, the use of CAR T cells, genetically modified lymphocytes who attack leukemia after infusion will become more and more available and hopefully also successful. So far for us, in most of the cases, CAR T cell treatment is reserved for patients who relapse post-transplant and who have no suitable donor and perhaps have no good remission quality before an allogeneic stem cell transplantation. So at the moment we sometimes use CAR T cells as bridge for allogeneic stem cell transplantation.
The forum study is particularly a very big success for the CCRI and also for our group, because it has a very high impact on how children who need a stem cell transplantation are treated.